Hi, I'm Dr. Gregory Piazza. On behalf of CME Outfitters, welcome to Real World Data for Real World Patients, a broadened lens to inform decision-making in venous thromboembolism. This series of activities is brought to you by CME Outfitters, an award-winning, accredited provider of continuing education for clinicians worldwide. This is our second episode in our BriefCase series, addressing disparities in care, assessing patient characteristics when determining next steps for anticoagulant treatment selection. Again, I'm Greg Piazza. I'm Director of Vascular Medicine at Brigham and Women's Hospital. I'm an Associate Professor of Medicine at Harvard Medical School. And I'm joined today by Dr. Carol Watson, Professor of Medicine and Cardiology and co-director of the UCLA program in preventive cardiology. Dr. Watson is also director of the UCLA Barbara Streisand Women's Heart Health Program. And she is the John C. Mazzotta Term Chair in Medicine at the David Geffen School of Medicine at UCLA. Welcome, Carol.
Thanks so much, Greg. It's really a pleasure to be here. This is such an important topic, and I'm happy to join in this discussion.
Excellent. Well, let's start off the discussion by reviewing our two learning objectives for today's session. After participating in today's activities, clinicians should be able to recognize the impact of racial and ethnic disparities on the care of individuals who are candidates for anticoagulant therapy, and also apply patient selection criteria for anticoagulation treatment that minimize these disparities and the unconscious bias that can be there in order to optimize outcomes. So by way of introduction, perhaps Carol, you can provide us with some background on the scope of this problem of VTE in the United States.
Absolutely. So VTE comprises deep vein thrombosis, DVT, also pulmonary embolism, PE. There were more than 1 million physician office visits and 211,000 emergency department visits with a principal diagnosis of VTE in 2016. Now, we know that the incidence will continue to rise because our population is aging, and as people live longer, they have more chronic conditions predisposing them. VTE incidence varies by race and ethnicity. Blacks are at greatest risk, followed by whites, Hispanics, and Asians. Studies suggest provider interactions with patients of color are less patient-centered, with fewer requests for patient input about VTE treatment decisions, less shared decision-making.
Thanks, Carol. So really, in terms of prevention and treatment, we know that anticoagulants are the mainstay of VTE management. So it's so important to make sure that we're using them as best as we can for all of our patients. Anticoagulants have a key role in reducing the risk of thrombus extension, recurrence, and embolic complications. They may help to also prevent post-thrombotic syndrome. When we think about the different anticoagulants, we have our parenteral anticoagulants, which could be IV unfractionated heparin, or injectables like low molecular weight heparin or fondaparinux. We have oral drugs, which include vitamin K antagonists, which typically means warfarin. And then we have the direct oral anticoagulants. And really, with all of these, we're trying to match the right medication with the right patients. And so now we want to get our audience involved with a question. So here's our question. Which of the direct-acting oral anticoagulants, or DOACs, have garnered the most clinical use over the past decade based on real-world evidence, or RWE? Is it A, apixaban and dabigatran, B, apixaban and rivaroxaban, C, dabigatran and edoxaban, D, edoxaban and rivaroxaban, or E, you're not sure? So the correct answer is actually B, apixaban and rivaroxaban. And as we can see here, trends in anticoagulation over time based on the real world evidence. And what you can see is use of apixaban, which is in blue, and use of rivaroxaban, which is in green, have really increased over the past several years. And that likely seems to correlate with increased publication of studies that are based on real world evidence. Carol, is this something that you think you see also on the West Coast? Certainly, I think on the East Coast, we've seen quite a bit of this.
This is exactly the same thing we're seeing. And I have to admit, I was not a particularly early adopter of the DOACs, but as the data kept coming out showing great efficacy and superior safety, it was hard not to make the rational decision. So we're seeing the exact same trends.
Absolutely. And since we're in the process of being honest with each other, I can tell you that I wasn't the hugest fan of real world evidence as that whole field started to develop. I really was brought up in this culture of randomized controlled trials, double blind, all of this stuff.
As was I.
Yeah, and then as you start to look at real world evidence, you start to realize it's really important for showing real practice for what we do in the clinic every day. Yeah. So it's wonderful that we're having this discussion.
Yeah, it was great when the real world evidence led us to some hypothesis generating studies that clearly and definitively showed us the benefits.
Absolutely. So now what we're going to do is we're going to present a case study. This is a case study of a patient named Gordon. Carol, what do we know about Gordon?
Well, let's talk about Gordon. So Gordon, I think many of us will recognize Gordon or someone like Gordon. He's a Black male. He's 67 years of age. He comes in complaining of a pain and swelling in his right leg that happened about 3 days ago. It's been going on continuously. He's got some comorbidities, hypertension, type 2 diabetes, hypercholesterolemia. Importantly, he had an unprovoked DVT 3 years ago. His social history is notable for an alcohol history. He drinks about 2 to 3 drinks each evening. You've tried to talk to him about that, but he's still drinking. He's never smoked. He works as a telemarketer at a call center, so he's sitting for extended periods of time. He admits he does not exercise regularly, even though you've had that conversation with him time and again. Okay. So what is this physical exam? He's about 5 feet 9 inches tall. He weighs 214 pounds, so that gives him a body mass index in the obese category, 31.6. His temperature is normal, heart rate's 88, blood pressure is 138 over 86, a little high. Lungs are clear. His saturation on room air is 95%. He's taking atorvastatin 40 milligrams once daily, hydrochlorothiazide 25 milligrams once daily, irbesartan 300 milligrams once daily, metformin 1,000 milligrams once daily, and insulin once daily 100 units subcutaneously. But let's hear from Gordon directly.
This is the second time this has happened to me in the last 3 years. The first time I went to the hospital where I was given injections. Then I took a blood thinner, but had to watch my diet and get tested regularly, which was difficult with my job. I remember getting nosebleeds and even small cuts that would take forever to stop bleeding. So I stopped taking it after a few weeks. Today my leg is very painful and swollen again. My doc has since retired, so I'm hoping you can help me out. I'll go to the hospital for the injections again, although I'm not crazy about shots because I'm already taking insulin every day.
So I think what Gordon had to say is, not only does it ring true with so many interactions that I've had with patients, I think the honesty that he gives us is so important, especially as we think about sharing the decision making with him on the best way to manage him going forward. As we think about discussion, Carol, we think about sort of what in Gordon's history and physical exam suggests a particular risk of VTE, and what sort of diagnostic tests should be done in the office and what might need to be done in the hospital. So what do you think about in his history that sort of outlines his risk for VTE?
So the obvious one is his prior unprovoked DVT. So we know he's at risk for a future DVT. Now he's shown us he's had another DVT. So he's someone who I'm worried about long term. And we need to make sure he gets effective anticoagulation for the long term because he has a number of risk factors. His obesity, his sedentary lifestyle, his hypertension, a number of things that place him at greater risk.
Yeah, absolutely. I think just recognizing those risk factors will help providers to cue into the need to look for VTE. Although, as you said, just that prior history should be enough to make sure that the diagnosis gets made in a timely fashion.
Yeah.
So Gordon gets a compression ultrasound, which is our standard test. Typically not done in the office unless it's a vascular specialist. Most likely requires referral to a vascular lab or the emergency department. And what they were able to find is that his right common femoral vein's non-compressible. So with the ultrasound transducer, they're pushing down on the vein. And if the vein doesn't collapse, if there's something in it that's keeping the transducer from collapsing, that's diagnostic of DVT. And unfortunately, that's what we find in Gordon. We find this deep vein thrombosis in one of the proximal veins, the common femoral vein.
Right. So we're worried about him. We were very worried before we got this study, and now we're doubly worried. We know he has a DVT, and he's at risk for not just local complications in the venous system in his leg, but obviously pulmonary embolus, which would be catastrophic.
Absolutely. So now that we know this about Gordon, let's check in with him again and see what he has to tell us.
My neighbor told me there might be oral medications. If so, I wish someone had told me about that a few years ago. My neighbor works at the local hospital, and she rattled off a bunch of names that I can't remember, let alone pronounce. But maybe you know about these?
Yeah, so I think that this is a great time for us, Carol, to enter into a conversation, a very nice two-way conversation with Gordon, where we understand his preferences, but we also provide him with the knowledge of the different options.
Exactly. And I think a lot of patients, when you offer them an oral medication versus parenteral, they're very happy. And B, one that has an easier administration, not as much monitoring and things, they're also very happy. But there is some concern. They say, is this as good? Could this possibly be as good? This is my health we're talking about. So not only do we have to offer them the benefits, we have to tell them that there are some potential risks and let them know exactly what the data says.
Absolutely. All part of that two-way conversation. Now, when we think back to Gordon's history, the question comes up, would he have benefited from a direct oral anticoagulant as initial therapy and maybe even extending it for secondary prevention so that he wouldn't have to have suffered this second event? And along those lines, could racial disparities or implicit bias have influenced his caretakers such that he maybe didn't get extended therapy or he didn't get the option of a DOAC? What do you think?
So it's impossible to know because we weren't there in that discussion. But what is clear is that he did not have all the information and data we would have liked him to have. It's not clear whether it was given or not, or whether it was not received. But in either case, he did not have the correct information. So I think one of the most important things we can all do as clinicians is make sure our patients are getting the information we think we're giving them. And again, I hear so often many patients like Gordon be described as non-adherent, non-compliant, and difficult. He's not. He's telling you he wants to do the right thing. He just needs the correct information.
And I think that's perfectly said. And I would love actually to have more patients like Gordon who want to engage in the conversation. And sometimes I think in the rush to talk with our patients. If we don't feel like they're necessarily receiving the information, we may not like sort of slow down and take the time that we need to. But
Exactly. This takes time.
this takes
But
time.
I think it's clear most patients want to do the right thing. We just have to empower them to do the right thing.
Absolutely. And Carol, as you mentioned, when we think about the options in DOACs versus the vitamin K antagonists, we know that the DOACs perform from an efficacy standpoint similarly to vitamin K antagonists. But tell us about that special safety, that superior safety that you mentioned earlier.
So that is literally what really got me over to the DOACs. The efficacy is equal, and as you showed very nicely, but the safety is superior. And that is big because anytime you're talking about anticoagulation, you're doing a balancing act between thrombosis and bleeding, clotting and bleeding. You don't want them to clot, but you also don't want them to bleed. And we know that's always been a problem with some of the other anticoagulants. What we saw with the DOACs was superior safety in terms of bleeding. Fewer major bleeds, in fact, fewer bleeds in those critical areas that we care about, like intracerebral hemorrhage, things that really some patients tell me they'd rather die than have a stroke. We don't want to have to expose our patients to any adverse events, but some of them are truly devastating, and we have to make sure we don't.
Yeah, and I think that actually is like one of the biggest parts of the conversation, because the word blood thinner itself is like almost stigmatizing. Patients feel like, oh, there's something wrong with me if I have to be on a blood thinner. And when I hear blood thinner, I think of bleeding. And so your point about the safety being superior is so key. I also think of it from a standpoint of convenience. Certainly we've been used to for decades, and even Gordon mentioned the injections. We used injections as a bridge to warfarin for so long, but now with the direct oral anticoagulants, we can either still use injections if patients feel like they want that, if they're used to that and they don't want to, they feel better receiving that, or completely oral monotherapy with rivaroxaban or apixaban, where they get a higher dose initially and then a lower dose. I mean, that seems to me like it would be very well received. Is that what you've seen, Carol?
That's definitely what I've received. Of course, there are some patients who are very used to their standard therapy. I go in for injections and parenteral therapy, and then they switch me to warfarin, and they feel comforted by that. But most of them, when I discuss the risks and the benefits, they understand why we're recommending this therapy and are very amenable.
Absolutely. And I love what you said there when we discuss the risks and the benefits. It's just, and it comes so naturally the way you say it. That's what we should be doing all the time. And when we do it, the patients are part of the process and they're more invested. It's really it's the goal.
Let me tell you what I use with patients that they really seem to resonate with. I say, everything we are trying to do for you is meant to make you feel better, live longer, or prevent something bad from happening. And when you put it in that context and talk about the benefits of any anticoagulation, the safety of DOACs, it's really clear that this is a therapy that we should consider.
I absolutely love what you just said right then. We have another question for our audience. On average, what percentage of risk reduction for VTE do DOACs provide when used for secondary prevention? Is it A, about 25 to 30%, B, nearly 50%, C, about 80 to 90%, D, more than 95%, or E, you're not sure? So amazingly, the answer is about 80 to 90%. There is just a substantial relative risk reduction for recurrent VTE when you use DOACs for secondary prevention. And as you mentioned, Carol, because the safety's there, it really ends up being a very sort of almost straightforward risk-benefit analysis, doesn't it?
Absolutely. That's, again, what dragged me over. I really was not an early adopter, and that's my confession here. And I'm so grateful that I saw the data and that it was so clear cut, because our patients are benefiting.
Yeah, absolutely. And then you heap on top of that real world evidence that shows that outside of the ivory towers of randomized controlled trials, these drugs still perform very well and are still super safe. It's wonderful.
Yeah.
And that's a big contribution too. So when we look at the different studies, and there have been so many trials focused on preventing recurrence in those patients that have suffered unprovoked or idiopathic, untriggered venous thromboembolic event, that's where we really see that 80 to 90% relative risk reduction. And that's a big deal for our patients, because the ones that have had an unprovoked event can have over a 50% chance of recurrence following the 10 years after the initial episode. So it's so important.
Yeah. And it feels so random and unpredictable to patients. It really does. A lot of them have described to me, they feel like they're being held hostage. They don't know when this is going to happen again.
The word random and unpredictable, I can't tell you how many times I've heard that, not just with the first event, but then if they're taken off blood thinners after 3 to 6 months, they could go 5-6 years with nothing, and then all of a sudden have their recurrence, and they weren't expecting it. So clearly, like you said, there's a feeling of uncertainty that's very dissonant. So we've got another question. What did a 2019 study by Nathan et al. Reveal about the use of DOACs for VTE in communities of color? Is it A, annual household income less than $75,000 was associated with a reduced likelihood of being prescribed a DOAC? B, Black patients were less likely than white patients to be prescribed a DOAC. C, disparities were evident only in patients without commercial insurance. D, unlike studies in atrial fibrillation, there wasn't a significant difference in prescribing frequency between Black patients and white patients. Or E, just not sure. And the correct answer is B. Black patients were less likely than white patients to be prescribed the DOAC. And Carol, we should unpack this a little bit.
Yeah, let's do that. So Nathan and colleagues performed this very nice study. They assessed the association of racial and ethnic and socioeconomic factors with DOAC use in VTE. They reviewed data on over 14,000 commercially insured patients who had an incident diagnosis of VTE between 2010 and 2016. The rate of DOAC use increased during that time from 0.1% to 65.6%, so that was good. But they found that there were racial and ethnic differences, as well as socioeconomic differences, that influenced uptake of DOACs. Black patients, they found, were less likely than white patients to be prescribed a DOAC. The odds ratio was 0.86, meaning they were 14% less likely. That was consistent with other studies like we've seen in atrial fibrillation. So we see these disparities in multiple modalities, multiple venues. Annual household income of greater than 100,000 versus less than 40,000 was also associated with greater likelihood of being prescribed a DOAC. That odds ratio was 1.5, means you were 50% more likely to get a DOAC if you came from a high income household. Now, we know racial inequalities in the US are very extensive and pervasive, and we've done a lot of sort of reckoning about that in the past year or so. Studies suggest that provider interactions with patients of color are less patient-centered. We don't ask them as many questions. We don't take their input as often, and we don't have them share in the decision-making like we should. Black patients may not be given the same voice to express their preferences for DOACs or other anticoagulants, and that's because there are some preconceived notions about what preferences someone might have, or maybe their ability to pay or ability to monitor. We just don't know. So we have to make efforts to improve equitable care. We need to make sure we have equitable medication uptake and utilization among all racial, ethnic, and socioeconomic groups. That is vital. Making sure we have justice in medicine is key. So that means every clinician needs to consider all of these factors, race, ethnicity, social determinants, at every interaction. And when we talk about the social determinants, that's basically everything non-medical that may affect your patient's medical care. Maybe where they live, where they work, how they live, how much money they have, etc. We know that many of these social determinants of health, they really do affect everything. They affect our access to healthy foods, safe places to exercise, high quality health care, physical environment. We may have them living in environments very heavily polluted, etc. That impacts a large number of things. So we think risk factors are just about patients, getting with the program and showing some resolve, but it's not true. Some of these things, their food choices, living in food deserts, etc., may impact their obesity rates. Many things, such as presence of living in a very polluted area with a lot of air pollution, can affect their hypertension rates, etc., pulmonary dysfunction. All this can lead to suboptimal outcomes. So we have to think of social determinants in every interaction.
I think that is just, it's perfectly put, and it is something that we need to constantly be reminding ourselves of. We're taught in medical school to really, almost in a way that it should be done for all of our patients, to ask about all of these different social determinants of health, to ask about living situation, to ask about food insecurity, to understand our patients' education levels, who's at home, all of these different stressors. And yet in all of the rush to get through our patients, to get through our clinic, where do we skimp? We skimp on the social determinants of health, if not other things as well. But it's so important in this era of recognition of disparities to try to get back to that process of getting closer with our patients and understanding our patients' journeys and struggles.
Absolutely.
Otherwise we could prescribe what we think's the best drug, but it may not get the outcome that we want.
We ask them to eat 5 servings of fruits and vegetables a day, not realizing they're on such a limited income, they can't afford fresh fruits and vegetables. And not only that, there's no grocery store in their neighborhood. We can't ignore all of these social determinants.
Right. It's well past the time of us ignoring these things. It's time that we have to stand for what we learned in medical school and what we know is best for our patients now, which is really understanding and taking the time. The system, we acknowledge, doesn't always facilitate that, but our primary commitment is to good care of our patients, and we have to work it out.
Exactly.
Yeah. So we're back to Gordon now, and here's another perspective from him.
You want to know my preferences for medications? That's something I've never been asked before. But now that you mention it, I would prefer avoiding shots if possible. Like I said, an insulin shot a day is more than enough as it is. Maybe a medication that doesn't require me to get monitored with regular blood tests, and one that doesn't put restrictions on food I can eat. And less problems with bruising and bleeding would be great, as long as I'm making a wish list.
I think Gordon is really describing what many of our patients would wish for.
Yeah, I think, the fact that it was sad to hear him say that was like one of the first times he'd been asked about his preferences. How do you approach that, Carol, in your clinic? Like, do you like, I'm sure it's ingrained, but how do you approach it? Like, how do you start that conversation with patients?
That's a really good question, because what we have to make sure we do is involve the patient in the decision making. But what we also have to make sure we don't do is drop decisions in their lap, which they're unprepared to make. So whenever I encounter a patient, I go through my thinking, my thought process, my reasoning, and this is what I recommend. How do you feel? And then we have a discussion. Here's what I recommend as the medically best option for you right now. You tell me what works with your life, and we work together. So again, I don't want them to just say, okay, there's all these drugs here. What do you want to do? No, I want to give them the best medical evidence and my best recommendation. And then I want to hear what they think and how that works in their life.
I love that, because I think that patients still do want a recommendation.
Oh, sure.
They want you to have thought about them and to show that you're invested enough to give them a recommendation. If you just drop the decision on their lap and say, we got a Pixaban, Rivaroxaban, Dabigatran, blah, blah, blah.
You choose.
Yeah, you choose.
It's like when I take my car to the mechanic and they say, do you want a carburetor or a transmission? I'm like, I don't know.
Right. It's not very caring, is it? You want to, giving a recommendation shows the patient that you've thought about them and that you care about them. And it's just the way you put it was perfect. Carol, in your practice, I know you've got it down where you involve the patients in the process of making decisions about their therapies, but not all clinicians do that. And some of them will say, well, I don't have time, or I don't feel comfortable doing it, but there are some clear benefits to doing that. What could you tell a clinician like that they could look forward to gaining by including this as part of their interaction with the patient?
I mean, you make really important points. This takes time. There's no way around it. And so I often say, listen, I know we need to have this discussion. Can you please set up another appointment where all we do is talk about this? Because, we can get reimbursed for that, and we can spend the time, and that's important. And the benefits, think about it. When we see loss of adherence to medications, statins, DOACs, et cetera, after a year or so, it's probably because at that midpoint, they're like, why am I taking this drug every day? I don't feel any different. It's not doing anything for me, and it's really expensive. So, you know what? Let me just stop taking it. But patients who understand exactly why they're taking it, what the risks and the benefits are, they're more likely to persist. Their outcomes will be better. So the whole system will reap benefits from that few extra minutes you take up front.
I think it's well said. It's an individual benefit for the clinician and the provider, but it is a systems benefit as well. So we're now back to the sort of conclusion of Gordon's case. He's treated as an outpatient and responds very nicely to direct oral anticoagulant therapy. Given his comorbidities and the likelihood of a future VTE, this time secondary prevention with a DOAC is emphasized, and he's very supportive of that. He starts taking some steps to lose weight and exercise regularly, and he's following his clinician's recommendations for regular follow-up appointments. So really, in a way, this has been a wonderful two-way interaction where we've shown more caring for Gordon by being involved and by including him in the discussion, and he's reciprocating with being more invested in his care. This is how it should work, right, Carol?
That's exactly how it should work.
Awesome. So we have our SMART goals to go over. Going forward after this program, reflect on your own clinical training and practice and consider ways that unconscious or implicit bias might impact patient care. Engage patients in shared decision-making, keeping in mind how social determinants of health can impact quality of care and ultimately patient outcomes. Stratify risk for venous thromboembolism based on patient characteristics and comorbidities. Apply the results of randomized controlled trials, but also be mindful of the role that real-world evidence has in dictating patient care for VTE. And then finally, assess the role of DOACs in primary management and secondary prevention of VTE. I want to thank you, Dr. Watson, for being just a perfect person to talk to us about this and to collaborate on this. Your
Thank you so
observation-
much, Dr. Piazza, for inviting me. This was a great discussion, and I think we can really help our patients if we think about these things more often.
Absolutely. I was going to say your observations and insights were spot on, and I hope that it resonates with our audience. I want to thank the audience for participating. This was a critical conversation to have. And, while Dr. Watson and I can talk about this for a long time, with having you as part of this session, we have a lot of hope that we're going to start to make some steps forward in addressing these issues. We hope you found it useful. We hope that you'll apply this to your own practice. Just a word about CME and CE credit for this activity. You can click on the link to access the post-test and then get your evaluation. And then you can print out your certificate or statement of credit immediately. You can also find other resources for clinicians and for patients on VTE through the Cardiology Hub. And there are other topics that you might find interesting by visiting the www.cmeoutfitters.com/cardiology area of the website. Definitely don't miss the other programs in the VTE series. We have real-world data for real-world patients, a broadened lens to inform decision-making in VTE, a CMEO podcast, and cutting through comorbidities, clearing the way to appropriate anticoagulation therapy in patients at risk for DVT and PE. So take advantage of those resources. Thank you again. Stay safe, everyone. And it was an absolute pleasure for both of us to have you participate.